if you don't do these annual checks, or if you screw something up in your report, we get a violation. So then I know that you didn't do your job. And it kind of bums me out that that's what we're evaluated against, is the absence of failure, right? As opposed to our contribution to making something better. And I think that's where the narrative really needs to shift. I want people to know what we do, in the sense of, that's Brad, and I know that he solves problems for us in radiology, and I know that he makes our images look better. Or I know that he gives us shorter turnaround time between exams. He helps us solve departmental problems, right, that have helped us in terms of quality care for the patient. That's where I want us to go.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Imalogics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Welcome back to Frame by Frame, Rethink Imaging. This is going to be part 2 of our conversation with Brad Lofton, talking about the commodification of medical physics, what medical physicists can do to improve quality at their facilities, and, just lightly touching on access to physics across the U.S. So, I mean, you're talking about physicists needing to be more involved, more than one stop by a year. I think for a lot of larger facilities and academic centers, like, that's very much on the table, right? They have medical physicists on site, but outside of that, they're, in rural places, like, how are they supposed to access a medical physicist to be, implementing these new quality practices?
That's a good question. I actually, I have a lot of sympathy right now for my academic in-house, brothers and sisters out there, just because I feel like a lot of academic centers are getting so big, and their community outreach, they're popping up hospitals. MD Anderson, I can't tell you how many hospitals they have in the greater Houston area, like a ton, right? And they have a lot more physicists on staff, and they're specialized in all those things, so they can accommodate it. But I feel like anymore, with the growth and expansion in radiology services, I know of a lot of in-house academic groups that basically function in a very similar way that we do, right? They're sending people out all the time. So I'm hoping that a lot of this conversation will resonate even with them. I think typically, and as it should be, they may have more time allocated towards some of the level 2, level 3 type work. But I feel like anymore, there's so much equipment out there. It's a problem of scale, right? Even they have a hard time keeping up with new building projects and new radiology departments coming online. So, as far as how to translate this, I think it starts in a couple ways, right? We at camp emphasize EQ even over IQ. Not to say that we don't hire smart people. I love everybody on our team. They're highly capable, but I really think that the ability to get along well with the people that you serve is a key component to bridging medical physics 3.0 into the community and rural hospital space, right? They have to know you. They have to trust you. They have to be able to call you on a whim if they have a question. So I think that is a key element, is just availability and building relationships, even in this field that is critical.
You just dropped Physics 3.0 a little bit. Can you just expand on that? I believe Physics 3.0 is an AAPM initiative, and I know that it's physics for every patient, but beyond that, that's about all I got, and I'd love to hear a bit more about it.
Yeah. So again, going back to the RadOnc example, this is for a long time kind of been their operating environment. Their default operating environment is MedPhys 3.0, right? Because they literally do QC for every patient, right? If it's like a stereotactic radiosurgery patient, they're there doing the QC in a patient-specific sense. They do chart rounds with everybody, so they'll know the course of treatment everybody is going through. It's very patient-oriented, and so just by nature. So I think what we're trying to do, and what Dave Jordan is really trying to spearhead as the chair of the MedPhys 3.0 within AAPM, is to really translate a lot of that thinking into the imaging physicists in nuclear medicine space. Again, it's a scale problem, right? There's a lot more imaging patients as opposed to cancer patients, but trying to fine tune ways that we can kind of bridge that physics for every patient gap, I think is important. And just to reemphasize kind of the point that I've been making up till now is I think we have more opportunity to do that if it's less about us doing only compliant work, right? Not being dismissive of compliance, but having to leverage tools in a more effective way to make ourselves more available to MedPhys 3.0 initiatives. So again, we do this imperfectly. We're kind of learning as we go. So one recent way that we have implemented MedPhys 3.0 in practice, in imaging practice, is my partner Jen Stickle was recently on a publication in the Journal of Pediatric Orthopedics on the novel use of O-arm following an open reduction of a dislocated hip for a walking age patient. So these are pediatric patients, but she was helping them kind of navigate how to best use an OR for this simple imaging procedure as opposed to taking an intubated patient to CT, just making a more efficient use of the tools that they had available to them. And I think that that's a great example, recent example that just was published, I think this past week, on how we can kind of bridge that MedPhys 3.0 into practice. It's more about process revision and protocol revision, because again, we can't walk alongside every individual patient in radiology, but what we do have is tools at our disposal, such as RDIM systems, radiation dose index monitoring systems, to kind of get a general real-time sense for performance of these protocols, using those tools to help us determine how to optimize those, how to refine those. A lot of people have questions, right, about the CMS requirements for image quality and what that looks like in practice.
I haven't heard of that. What is that? The
Right. Well,
sorry.
I point you to previous podcasts.
Oh,
So,
I had to.
and
Sorry.
I get those, right? I totally understand the pushback and the reservations.
Yeah.
At the same time, like, I'm kind of excited about having some means of evaluating patient image quality in a real-time sense, with as imperfect as it can be. Because again, I'm thinking from like a baseline state. What is this doing? How is this trending in time? And using tools like RDIM tools, like Imalogics, to help us kind of get a real-time sense for image quality, I actually think is exciting, right? I think it's another tool in the tool belt of a quality manager. And that's a good example, I feel like, of MedPhys 3.0 in practice.
Well, yeah, I mean, like, I know that lots of people have a lot of feelings on the measure itself, but, we were just at AAPM and talking to folks, and at the end of the day, some of the folks who are already, using our CMS dashboard, regardless of like how perfect the measure is, they're already improving. Right? Like they are already looking in, changing their behaviors and getting better. And like at the end of the day, it's kind of what it's about, right? Like, is it perfect? No. But is the result of it, net positive? I mean, at the end of the day, I mean, I think yes.
Tools need to be validated. They need to be tested, right? I'm totally for being skeptical of certain tools at our disposal, testing them out. I do think that we have this mentality sometimes as imaging physicists that, we're just going to do it the way that we've always done it. I don't really care to learn that thing, or I'm going to build my own tool, or whatever. And I've never fully understood this. I think that we have a lot of technology that is coming online to help us get a better picture of the instantaneous health of our department in terms of quality and safety. You have RDIM tools, right, that we've already discussed, but you also have vendor-specific tools. And I don't know, I'm extrapolating. Maybe this isn't a thing that's going to come out soon, but what I do know is like a lot of the mammo rooms that we test, they have feedback. They track tube cycles, and basically a mammo machine can give an indication to a field service engineer if they're getting up above the operating threshold in terms of tube cycles and you may need service. Like they will notify them in advance just based on tube cycles. So my mind, I'm like, where is that going to go? Like, are we moving towards more quality control tool availability at the vendor level, right? Siemens has team play. We have all these things that can track utilization of devices, right? The data is there. And it makes me wonder sometimes kind of where this is going in terms of the tools that we're going to have at our disposal to actually more actively monitor, right? That makes people maybe a little bit nervous. And I'm certainly not saying they shouldn't be validated. But I am saying if these things are available, if they can help you to do your job more efficiently and better, why don't you use them? Or at least look into using them. It doesn't make a ton of sense to me.
No, it doesn't. And like, maybe this is a stupid question. I mean, no, it's not a stupid question. But when I hear you say, like, some folks are in this boat of, we do it this way because it's the way it's been done. I'm like, to me, I'm like, what? That is antithetical to science and progress. What are you talking? I am someone who hates tradition. I love what's new. I love thinking ahead. I love next steps. And I'm like, how, especially in this field, are folks like, oh, well, I mean, that's how we've done it. It's like, that's crazy.
Credit to Nick Bevins, who is a imaging physicist in Maine. He sent me a screen capture of it was a meme, I think, and it was a poster that had somebody being gored at the running of the bulls, right? And below it, I can't remember what the subheading was, but it basically had in big block letters, it said tradition, right? And it had running of the bulls has been going on for, how many hundreds of years. But it's like, okay, tradition is great, but you're still going to get a bullhorn in the rear end, right? Is that really, is it worth it to keep that tradition going? Maybe it is. I don't know. Again, I'm sure I'm offending somebody, so I apologize. I just thought that was funny, and I'm sorry I butchered that subheading because it was funnier than that. But it made me think of that Nick Bevins meme.
We might have to dig up that meme and
do some googling.
Throw it on the screen for folks so they can see
Right.
the real thing.
Another couple just examples of MedVis 3.0 in practice, right, is we cover MIBG therapies at a pediatric hospital. And so somebody is on site to actually prepare the room, to verify the written directive, to oversee treatment. We're required to do this in the state of Colorado because Y90s are treated as brachytherapy. But I think it's a good thing because every Y90 that's done in the state, and there's a lot of them, we actually have to be on site for, right? So I feel like a quality gain when we're on site. We're overseeing the dose draw, we're overseeing the administration, we're there to help the IR physician talk through any questions they may have. A lot of times we're there with the vendor, but I think in terms of MedVis 3.0, physics for every patient, that's a really kind of real-time example of something that's a highly complicated procedure. It has a high severity score. If we're thinking in terms of FMEA, a Y90 procedure goes wrong and you could really misadminister, right, and hurt a patient. You could have a major spill and you could contaminate people and they bring it home, and a lot of bad stuff can happen. But kind of having that on-site personal attention, I think, that's kind of where we need to be. We need to be more clinical. We need to be in clinical space. We need to be interfacing in those types of complicated procedures.
We touched on the CMS measure. You're talking about medical physics 3.0. What regulatory changes, in your eyes, if you could all of a sudden start spewing out regulations and measures, where would you be focused?
I think a lot of where we need to go is codifying the necessity for the individual, right? The QMP, the qualified medical physicist. And then alongside that, regulatory flexibility to allow them to oversee their program as they deem appropriate. And this is kind of the work that we're trying to do right now in the Smart Reg subcommittee. And, more to come. We're not there yet. But if I'm just free-form dialoguing on what would be an ideal, it would be make sure the people who have the credentials are in place, and then give them the latitude to build the program according to what they think is best for that specific facility, what that specific department. That doesn't mean we do, carte blanche away with regulatory all benchmarks that really facilitate reporting requirements if somebody is injured, things like that, we keep intact. Again, it's going to sound like I'm advocating for less. I'm actually advocating for more. I am trying to empower the qualified medical physicist to run the program at their discretion, right? And it could be under the oversight of others. It could be there could be other pathways. We don't prescriptively regulate the practice of medicine. We do regulate by licensing who should be a physician, right? So why is it different for physicists? I think that we need to have the latitude to run quality programs in accordance with their needs, the tools that we have available, right? Giving that kind of flexibility to facilitate kind of a more FMEA approach, and even using that as a tool, I think would be that's my ideal, right? Not that we have to cover these things just because we said that we did them. It could be that I don't have to do that because I've justified that historically, that it doesn't need to be done. And we also have these other things to enhance our detectability. We use this type of QC that the techs do. There's lots of different ways you could go about it.
It's so interesting. Like, I've spoken to a lot of physicists at this point about a lot of different subjects, and it's always felt very, it has felt prescriptive and kind of black and white, a lot of these conversations I had. Obviously, there's nuance when we're talking about dose and image quality, and, if I never had to have 600 more conversations about dose, maybe I'd be happy. But, no, I love talking about those. The way you talk about it, it sounds more like art than A plus B equals C.
Yeah, I mean, I think it is. I think it is an art. And again, we do it imperfectly. I heard somebody say once, the first time they met their department chair said, I don't know what you guys do, but I do know when you don't do it, right? And what his point was is, if you don't do these annual checks, or if you screw something up in your report, we get a violation. So then I know that you didn't do your job. And it kind of bums me out that that's what we're evaluated against, is the absence of failure, right? As opposed to our contribution to making something better. And I think that's where the narrative really needs to shift. I want people to know what we do, in the sense of, that's Brad, and I know that he solves problems for us in radiology, and I know that he makes our images look better. Or I know that he gives us shorter turnaround time between exams. He helps us solve departmental problems, right, that have helped us in terms of quality care for the patient. That's where I want us to go. I know what they do as imaging physicists, because I know that we have, fewer misses, right? We don't miss anything as a radiology group because our images look great. And in part, that's because we're great radiologists, but we feel comfortable because we have great imaging physicists behind us. I think that's where we have to shift the talking points. Again, these guys help us integrate technology into our department, right? I can trust this tool. I'm sending off these MRI images for whatever analysis, ADC, T1, T2 analysis. I can feel confident that the results I get at this location are the same at this location, because Brad has, not Brad, it wouldn't be me, it would be our MRI guy. But I know that an imaging physicist has validated this, right? They've made me feel confident in the tools that we use. So having us be kind of an ongoing resource, as opposed to this person that comes in the middle of the night and leaves a report, and it's a very beautiful report, it's a clean report, and it says all pass. Again, I'm not saying there's not a place for that, but that needs to be kind of, I think, more and more less of the focus of the imaging physicist in practice in nuclear medicine.
Let's think about, this current or, next generation of medical physicists. You're someone who's pretty passionate about training. Like, how can we equip physicists with better interface skills so that they can push back on this box checking and kind of commodification culture, and start to, how can folks out there start to make this pushback, in your mind?
I think physicists need to, number one, take leadership classes. Okay. I think that they need to be better communicators, uh, vis-a-vis, Dr. Sameh and I know Dr. Millman have been big on communication of risk. These are important conversations to have. The ability to have communication or to have a conversation with somebody is critical in our field if you want us to thrive as a specialty. So I would say start there. Start with asking yourself questions. If I'm a new physicist, I want to ask myself, why am I doing what I'm doing? If what I'm doing fails, what is the end result going to be to the patient? And it could be severe. It could be a really important test. There could be something that we're not doing that we need to be doing, right, on an ongoing basis. Ask yourselves other questions. How often does this thing that I'm doing fail? Are there other means by which this failure would be detected if it weren't me coming in once a year to do it? So I think ask yourself this kind of FMEA framework questioning is a good place to start. Think in terms of risk assessment, I think is where we need to shift our thinking. I think the other thing, kind of in line with the EQ stuff, right, the emotional quotient, we have to stop being default compliance officers and in a punitive sense, right? Our goal should be the people that we serve are comfortable with us so that we can go to them. And if we see a safety gap, if we see a compliance gap, we can communicate that verbally to them. We can have a meeting with them. We can give them tools and training to improve those gaps. Not just a kind of finger wagging mentality. I think we really need to embrace the partnership aspect of what we do. And that goes for in-house physicists. It goes for private practice groups like mine. It goes for everybody. The other thing that I think we need to do a better job of in both scenarios is, do we know our radiologists? Right. That's something that we really, it's unfortunate. I was hired on at camp kind of specifically to cover just a few hospitals. So I was functioning as an in-house physicist. But I know that Jerry really wanted me to take the time to get to know our radiology group, right? To better understand what their pinch points were, to cultivate that relationship. And on some level that worked. And I still know those guys. A lot of them have been practicing since I've been around. But at the same time, this goes back to the time as a resource. There's only so much time in a day. And if the default practice has been compliance, that actually ends up sucking a lot of time because there's a lot of equipment out there. There's a lot of RAM licenses out there. There's a lot of things. And as we've grown, we've really tried to put people in positions to succeed, to better address kind of those things and to be able to kind of leverage their expertise for certain aspects of compliance. And it's helped so that we can focus more on the level 2, level 3 stuff, the relationship building stuff. But again, it's hard to do if you don't have a big team, right? And so if you're just a couple physicists for a smaller hospital system, that can become difficult to do. But I think getting to know your radiologists in the way that they would feel comfortable reaching out to you and saying, hey, can you help me figure out what's going on with this artifact on chest radiographs? I think that is a huge aspect for people coming into the field out of residency, that they need to hone those skills. They need to embrace the relationship.
Yeah, I mean, and it almost sounds like I almost hear like a challenge the other way as well, right? Like, radiologists, get to know your physicist. Like, communication is a two-way street, right? Like, the onus of responsibility is not exclusively upon the physicist, but like the whole body for which the physicist is the nervous system, to call back.
Yeah, it's interesting you say that. In not just radiologists, right? Ordering physicians in the ER, that's a big utilization. I think is a big. It's a target-rich environment for us as imaging physicists. I had a radiologist friend of mine recently told me, he said, people talk about low dose all the time, and he covers, I think, a hospital system somewhere on the East Coast remotely. And he was commenting the other day, he was like, this hospital they're dialed into low dose CT. But when I look at the images look like crap. And that's a problem, right? It's good that you're delivering low dose, but your images don't look great. I don't know, I don't know the physics group. I don't know if they pass their protocol inspection, on annual surveys and stuff like that. I'm assuming they do. But he said, in my mind, it shouldn't be low dose. It should be no dose or clinically appropriate dose. And what he meant by that is, as a radiologist, they read a lot of studies that didn't need to be done in the first place, right? You could have done a D-dimer test, or you could have done some other means that is quicker, more cost effective. But imaging a lot of time I'm a big advocate for imaging. I think we need to expand screening programs. I think that's another place that we could get into as imaging physicists. But his point was, we have a utilization problem and we're already strapped. There's a shortage of radiologists, but we're reading a lot of studies that probably didn't need to be done in the first place. And so again, this is sort of a level 2 educational component that we can step into as imaging physicists, right? So kind of facilitating those relationships and identifying yourself so that an ER physician knows that we have imaging physicists available that we can have these conversations with, and we can talk to the radiologist. We need to be integrated in that clinical care pathway.
Right, like desegmenting the beast to some degree, right? Just like looking for that cohesive line of communication. Brad, we're starting to kind of get at the end of our time today, but let's kind of look forward and look to the future. What would be a headline or kind of like a litmus test, 5-10 years from now, signaling to you that things are like on the right track, right? Like, what would you look for as a signifier? Like, yes, things are moving into the right direction.
I think it's my hope that one day, if you were to ask a department administrator or a radiologist what we do, instead of the answer being, I don't know what you do, but I know when you don't do it, or he tests my equipment, it will be, they solve problems for us, right? That would be music to my ears. They are a problem solver for us in radiology. You asked, what trainees coming into the field could do a second ago, and another one I would add to that that's related to what I just said is know how a radiology department works, right? Know the ordering process, map all that out, know how reimbursement works. At least have some idea, right? Because money talks. We have to know kind of the financials behind a radiology department. I think these are things that we need to be educated on as imaging physicists, because again, we can't look at this as, this is my disparate role. I do quality assurance on this once a year. That's it. It can't be that. That's not how healthcare works. And if we're looking at identifying opportunities to show value, we have to know how the department works at large. So I would say that, in the future, I would want somebody to look at their imaging physicist and say, that guy or that girl solves problems for us. That's what they do. I would love to see sort of risk assessment tools and FMEA be kind of a standard of practice in imaging. I think it's useful. It's not perfect, right? But I think other things that I would like to see is a retrospective study that shows that miss rates for radiologists in the country have gone down, 10% in 5 years. And that could be because of the role of the imaging physicist in the imaging chain, but could also be because of new tools coming available online, AI tools. And us, working with the clinic to integrate these tools, I think is a big one. And then expanded screening, right? We've seen lung cancer screening is a powerful tool, breast screening, powerful tool. What other things could we leverage imaging for to identify problems well in advance, to be prevential as opposed to retrospective in our radiology practice, partnering with people with radiologists who kind of have that vision for how can we actually expand imaging to make it a more powerful diagnostic tool so that we can get on the very front end of a lot of these disease processes. If you wanted to see how, maybe a future discussion would go on rural specific issues. We actually, camp has a subcommittee that we formed to kind of address concerns with rural communities. So rural hospitals, it's a different environment, right? Because in the Mountain West, there's all this land, not a lot of people on it. So there's a lot of drive time to all these locations, these smaller hospitals and stuff. And so it's inherently inefficient, right? It's a travel expense to us and to the client, and we're trying to constrain cost to them. So we're trying to identify ways that in oncology and in imaging, we can better serve our rural community partners. And maybe, in a few months or in a year from now, we'll have kind of a more robust approach. Right now, it's just to give like price breaks, but maybe we'll kind of have some more fleshed out ideas how we can, use tools like Imalogics to better serve these communities. We could do something at that point, but yeah, that we can talk about that in the future.
Well, cool. Brad, thank you so much for joining us today on Frame by Frame. It has been an absolute pleasure having you, and I can't wait to have you back.
It's been a lot of fun. Yeah, thank you, Chris. I appreciate the opportunity.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.